Hi, and welcome to Why Do We Do That? A psychology podcast that deconstructs human behavior from the perspectives of social scientists, psychologists, and others that use applied psychology in their work. I'm your host, Dr. Ryan Moyer. In this episode, I sat down with Dr. Mark Ruffalo. Mark earned his MSW with a specialization in mental health from the University of Pittsburgh. He completed additional training in psychoanalytic psychotherapy and holds a doctorate degree in psychoanalytic studies. Mark is currently a psychotherapist in private practice in Tampa, Florida, and serves as instructor of psychiatry at the University of Central Florida College of Medicine and adjunct instructor of psychiatry at Tufts University School of Medicine. He has broad clinical experience in the psychoanalytic treatment of mood disorders, personality disorders, and psychosomatic illness, and has a particular interest in the psychotherapy of schizophrenia. I sat down with Mark to discuss psychosis and psychotic disorders. While it's common in everyday life to interact with someone experiencing anxiety or depression, psychotic disorders are much less common. It was interesting to hear some detailed examples of how these types of conditions present in actual patients. One thing I noticed right away about Mark is that he has a great appreciation for the history of psychiatry. He emphasized the importance of being open and honest about the historical problems found in the treatment of psychotic disorders. Consequently, I'm convinced that just because a field of medicine engaged in questionable practices at one point in history does not mean that the foundational philosophy is wrong, or that a commitment to change can't pave new roads based on scientific evidence. Also, perspectives on specific disorders can be fluid, and sometimes the first step in creating coherent, evidence-based classifications involves speculation based on clinical experience. If you're curious about one of the most intense psychological disorders, this episode is for you. Enjoy. Okay, today I am here with Mark Ruffalo. Thank you so much for being on the show today.
Yeah, thank you so much for having me. I've been looking forward to this.
Great. So today we're going to be talking about a lot of different topics. We're going to be talking about primarily psychosis and psychotic disorders. We're going to be talking a little bit about schizophrenia, as that's one of the more popular psychotic disorders. We're going to be talking about a little bit about the history of treatment of these types of conditions. So I guess we might as well start by giving the audience an overview of psychosis. What are some of the features associated with psychotic disorders?
Yeah, so psychotic disorders are historically considered to be amongst the most severe of the psychiatric conditions. The term psychosis is generally defined as a type of condition in which the patient experiences some break with reality or break from reality. That's why sometimes you hear the term psychotic break used.
Right.
The term is in contrast to an older, sort of out of date term, neurosis, in the classic sort of psychoanalytic lingo, excuse me. So, neurotic disorders, we might sort of define these as mood disorders and anxiety disorders today. And these were differentiated classically from psychotic disorders, which involved some disturbance in the patient's ability to think clearly. And often in these disorders, there are perceptual abnormalities, including hallucinations, delusions, and some other symptoms, which we'll probably get to. So, but psychosis is not a diagnosis in and of itself. Psychosis is a term that refers to a syndrome. Um, so when we say that someone is experiencing a psychosis, it could be the result of a plethora of different types of disease processes, medical disease processes, or psychiatric disorders. So psychosis, in fact, really is just the term for a syndrome. It doesn't really tell us much about the nature or the cause of the problem etiologically.
Now, I'm under the impression that you can actually get these, bouts of psychosis from drug use, but then it could also be something that is potentially genetic. Are there two different versions where, like, is there something different between the drug-induced psychosis versus someone that has had that is diagnosed with schizophrenia?
Yeah, that's a great question. And we see drug-induced psychoses all the time. I used to work in the emergency department. And if someone came, in under the influence of methamphetamine, for instance, or if they had done a lot of cocaine or other stimulant drugs, which target or work on dopamine, which is implicated in some way in psychosis, then you can certainly see psychosis occur secondary to drug intoxication. Um, Individuals with psychotic disorders, however, can and do become psychotic or experience symptoms of psychosis independent of drug use or intoxication. Now, sometimes they can use drugs, which can worsen the symptoms or perhaps trigger the onset of the symptoms. But we're really talking in some respect, at least, about two very different phenomena. A drug-induced psychosis, which generally has a good prognosis. The person comes down off of the drug, may be started on a neuroleptic medicine for a short period of time, and then they clear in short order. And psychotic disorders tend to be longer-term conditions. That's not always the case. We can talk about some of the different types of psychotic disorders, but that's sort of the difference in a nutshell.
So let's just jump right into schizophrenia, which is probably the most popular, the most well-known psychotic disorder. You mentioned that some illicit drugs that act on dopamine can create these breaks from reality. I would imagine that schizophrenia, you get these without the drugs. Could you talk a little bit more about dopamine and the structural areas that are associated with schizophrenia in the brain? Have we identified the different parts of the brain that are different from an average person?
Yeah. So this is an area that is still really being worked out in the scientific world and in the scientific literature. We do know that there are some changes in the brains of individuals who have been diagnosed with schizophrenia. Schizophrenia is the classic psychotic disorder. The term comes from Eugen Bleuler, who wrote a book in 1911 called Dementia Praecox, and he sort of he gave the term schizophrenia to denote this illness. Dementia praecox, just as an aside, sort of was an earlier idea that literally meant early dementia, and Bleuler and some of his followers realized that, well, this is really not the same as a dementing illness like Alzheimer's disease. It's something different. Schizophrenia, I believe, comes from Greek for split mind. And there's a lot of confusion around the term because a lot of people associate it with multiple personality disorder or
Right.
what's now called dissociative identity disorder. But that's not. Those are two very very different types of conditions. But so in terms of organic theories of schizophrenia, the dopamine hypothesis has been a recurrent somatogenic theory or hypothesis, meaning biological theory of schizophrenia in the 20th century and into the 21st century. What we've learned in the past 50 years is that schizophrenia is much more complicated than dopamine, which is a neurotransmitter. It's a chemical that we all have in our brains. The antipsychotic agents, the drugs that are used to treat schizophrenia, target primarily the dopamine system, and they tend to work for
Mm.
many patients. Generally speaking, I don't think we can consider these drugs a cure of the illness, but they work on dopamine. And for this reason and some other reasons, there is a good belief that schizophrenia has something to do with the dopaminergic system. Interestingly, Parkinson's disease, which is a neurological disease, also has something to do with dopamine. In fact, in Parkinson's disease, there is, in essence, a depletion of dopamine. And the treatment for Parkinson's disease is a drug called levodopa or L-dopa. And what they learned many years ago was that if you gave a Parkinson's patient too much levodopa, then they would begin to hallucinate and they would become psychotic, very
Wow.
similar to what you would see in schizophrenia. So sort of with that information in mind, there was this sort of idea, well, there must be something to this idea of dopamine. We now know, 50 years later about that dopamine is only part of the equation in schizophrenia. This simple sort of dopamine hypothesis is outdated. But certainly we cannot ignore the evidence for the implication of dopamine in psychotic disorder. In terms of what you see in terms of the neurological findings, probably one of the most robust findings is ventricular enlargement. That's an enlargement of the ventricles in the brain. And roughly, at least to my understanding, maybe 50% of schizophrenia patients demonstrate this finding. Um, there's some confusion as to whether this is, well, it's certainly not diagnostic of schizophrenia. Ventricular enlargement occurs in other medical syndromes. And then there's the question, which is really sort of a philosophical question. What we're seeing when we look at the brains of schizophrenia patients, are we seeing the cause of the disease or are we seeing the effect of the disease?
Right.
And this is a very difficult question to answer. And I think that a lot of the excitement in neuroscience really fails to address this question, right? Are we seeing in the neuroscience literature and the brain scans, for instance, are we seeing the mere consequence of a psychological process as opposed to a more top-down neurological disease, and that's still being worked out and trying to be understood. So you see
Hmm.
ventricular enlargement, and then there's also evidence for changes in both white and gray matter, and changes in the prefrontal and medial cortex of the brain.
So let's go back to early views on schizophrenia. In the little bit of research I did, it kind of emphasizes this sort of pre psychoactive medicine versus post. It seems like there are a lot of changes upon my small amount of research. Could you just paint the picture of mental health professionals and how schizophrenia was categorized before these psychoactive drugs came around?
Yeah, so that's a really wonderful question. And I think it's so important to know a little bit about the history, because I think when we know history, we are just better informed in terms of how we look at patients and their problems today. A lot of what we believe today has been theorized many years ago before by someone else. So, in essence, when you look at the history of psychiatry, there's a couple of major figures that stand out when it comes to schizophrenia. The first is Emil Kraepelin, who is kind of considered the father of modern scientific psychiatry. And Kraepelin, who was German, believed that schizophrenia was fundamentally a biological disease. He didn't really have much faith in the idea of psychotherapeutic treatment for schizophrenia, and adopted a pretty hard-lined biological stance on schizophrenia, in essence, arguing that there's really no point to trying to make sense of the symptoms, that the patient has a brain disease. And in time, we will more fully understand the underlying sort of neuropathology. Then along comes Eugen Bleuler, who in 1911 writes Dementia Praecox. And Bleuler adopted a more sort of biopsychosocial model of schizophrenia, leaving the door open to psychological etiology. And you see this also in the early work of Adolf Moyer, who was the first psychiatrist in chief at Johns Hopkins Hospital, who argued that perhaps in some cases a psychological cause could be identified in patients who would go on to develop schizophrenia. in the middle 20th century, we had the heyday of psychoanalysis in the United States, and many of the analysts who were writing during that era, including Frieda Fromm-Reichmann and Harry Stack Sullivan, argued that the etiology of schizophrenia, the cause of schizophrenia, was chiefly psychological, and placed a lot of blame, at least Fromm-Reichmann did, on the parents of the schizophrenic patient, including the mother, and her sort of ideas came to be known as sort of the theory of the schizophrenogenic mother. This idea that the mother of the patient was the cause of schizophrenia has long been discarded. It's done a lot of harm, I think, to families and to parents. Um, uh, in the sort of in the latter half of the 20th century, you have theorists like Silvano Arietti, who was one of my major influences, who really argued that a pluralistic approach to the disorder is necessary. A sort of biopsychosocial approach is going to be most helpful, taking into account structural and neurological causes, or at least correlates of the disorder, the early environment of the patient, including the family dynamic and the experiences of the patient through their childhood and adolescence. And then sociological or social factors, looking at how these might contribute to the onset of schizophrenia. One finding that you may find interesting as a social psychologist is that schizophrenia tends to occur more commonly in urban areas than in rural areas. And so there's a sort of a social component here as well.
Well,
Some
and also,
yeah.
I mean, I believe one of the interesting tidbits that I remember was that schizophrenia is one of or these related disorders, psychotic disorders, are ones are seen across all types of cultures globally, or at least it's more likely than other types of disorders to be found in all cultures. Is that the case?
Yeah, I mean, when you look at the prevalence of schizophrenia as the major psychotic disorder across the globe, it's pretty consistent. It's about 1% across the globe, found in every culture on Earth.
Well,
And
and sorry to interrupt, but it's interesting that someone would push a psychological cause when you see it so prevalently at the global level. It almost implies like there's something about being human that can go wrong to create this, push you down this path.
yeah, yeah, I agree with that to an extent, right? I mean, you've got to, I think with that knowledge in hand, you have to adjust your theory and your model to make some sense of this fact that it is seen everywhere. And it's certainly not to discount the psychological factors, but to try to incorporate them perhaps into a broader theory or hypothesis as to what's going on with the schizophrenia patient. Yeah.
Now, uh, most most people probably have never um, interacted with someone that is suffering from schizophrenia or a psychotic disorder. You've had a lot of intimate experience dealing with serious cases. What is something that you've learned from dealing with these patients that the average person wouldn't know or would be mistaken to assume from either watching a film or maybe even reading articles about somebody with schizophrenia?
Yeah. I think the thing that stands out most in my mind is that even in the sickest of patients, even in the patients with the most severe and the most grave disease, there's a part of the patient that remains healthy. There's a part of the patient that's able to engage with you, say on neutral subjects. When I was completing my internship at the University of Pittsburgh, I was one of my first days on the psychotic disorders unit, and the psychiatrist, who was an older fellow, he said, Mark, one of the best things that you can do while you're here on the unit is to make sure you check the sports scores uh, before you come in the morning, because the patients like to watch the Pirates and they like to watch the Steelers. and they'll talk about that stuff with you, right? They may believe that the CIA has implanted a microchip in their brain and is monitoring their every thought, but you sure as hell better believe that they know that Ben Roethlisberger threw 3 touchdowns yesterday against the New England Patriots. So I think there's this misconception that if the patient has schizophrenia, they are totally lost, that they are completely in their own world and they have no contact with the rest of the world. Now, I think it's probably true that in a very small percentage of patients, what Bleuler would have called catastrophic schizophrenia, which involves a complete degradation of the personality, that's probably true in those patients. They really are closed off from everything. But that is by far the exception, not the rule. That most patients can engage quite well and quite normally on a range of subjects. And I think that's the part of the patient when you're working with them in psychotherapy or when you're treating them pharmacologically that you have to get in touch with. You can't just sit there and talk to them about their symptoms all the time. You're going to get nowhere. You have to engage with them on the areas of life in which they are capable of engaging and engaging normally. And so I would say that's probably one of the biggest misconceptions.
Okay, so we're definitely going to circle back to talk more about the history of treating psychotic disorders. But I did want to ask you one thing on this line of the internal experience of schizophrenics and those with psychotic disorders, which is, are individuals with schizophrenia self-aware of their hallucinations? In other words, for the listeners, are they able to cognitively say that this is a hallucination, or can they be taught that this is a hallucination? Or is it the case that it's just all sort of muddled up and that's not really a target?
Yeah, that's a great question that really attempts to get into the inner world of the patient and understand what the patient is really experiencing on a day-to-day basis. And the answer varies very widely. Some patients of mine are able to say that when they hear voices out in the hallway of people talking about them or talking to them, that they're aware at some level that that's a product of their own mind and that's a hallucination. Some people have voices that really it's very difficult to discern whether this is a hallucinatory experience or it's occurring in outside reality. So there's really great variability on this topic. Over time, I think with good psychotherapy, the patient can be taught more or less to be able to identify what is a hallucinatory experience versus what is something happening in the external reality. Now, this takes time, sometimes years in treatment and therapy. But it can be done. Not every patient is capable of it. And very often in the very early stages of the disease, the patient really lacks any ability to be self-aware. Arrietty used to write about a concept that he termed psychotic insight. And it's not what you might imagine. When we talk about insight in psychotherapy or right, it's usually implies that the patient has come to some understanding as to why they have symptoms and now they're able to do something about them. Right. If I get depressed after a breakup, well, maybe that has something to do with my early relationships, failed early relationships with a parent or something, right? The patient has developed insight. But when Arrietty was talking about psychotic insight, he's talking about how in the early stages of the disease, of schizophrenia, the patient succeeds at putting it all together, meaning if they start hearing a voice, they develop psychotic insight and they say, well, now it makes sense. The White House is actually I have a direct line to the White House, and that's why I'm hearing these voices, right? So that's the idea of psychotic insight. So in the early stages of the process of the disease process, the patient usually isn't able to say to be self-aware enough to say that these are hallucinations. That can come in time. as the patient, in essence, gets used to having the disease with treatment, with medication therapy, and the like. So a lot of patients that I see who I've been working with for years might still experience hallucinations, but they're able to say when, for instance, they're out in public and they might hear someone talking negatively about them, they're able to say, well, I know that that person really didn't say that. That was a figment of my mind. And they've learned to be able to recognize that as a symptom of their condition.
Yeah. It seems I thought of a few things when you were sort of explaining this process. I mean, it sounds a little bit like, I mean, it reminds me of how you would try to use therapy to treat somebody with social anxiety or a phobia, which is these intrusive thoughts come in and they have to be dealt with, they have to be filtered. And that most people don't have the filter to begin with. That you have to train up the filter.
Yes.
Um, the so I want I'm very interested in hearing more about the history of treating, because I know
Yeah.
that's particularly interesting to you as well. Um, I believe it was the 50s when we first started seeing the antipsychotic drugs starting to become used. How did that, or what were the impacts of the advent of those drugs?
Yeah, so I believe it was 1952 when chlorpromazine, or the brand name for that drug was Thorazine, came on the market. It was discovered serendipitously by accident, as many of the early discoveries in psychopharmacology were. Um, it was a drug that initially had a very stony or muted reception here in the United States because a lot of psychiatrists didn't subscribe to biological theories of schizophrenia. They were psychoanalysts and they didn't really want anything at all to do with medicine. So, whereas you saw chlorpromazine take off in Europe and some other places around the world, in the United States, there was a lot of hesitation amongst academic psychiatrists to tinker with the brain because what was really going on was a psychodynamic problem, right? So, in essence, the pharma companies lobbied state governments to have the governments try out Thorazine and the related drugs on their state hospital patients, and lo and behold, they found that the drug worked actually rather dramatically. And in the 50s and in the 60s, you have a period of what's known as deinstitutionalization. We used to have massive state hospitals in this country. We still have state hospitals, but they're operating at much lower capacity. We had at one point close to 600,000, over a half million people in state hospitals in this country. And by the early 70s, after the discovery of the first neuroleptic drugs, that number was closer to 200,000. And right now, I think there's approximately 34,000 state hospital beds in the U.S. So a great reduction, attributable to many different causes. But one of the major causes was the discovery of the neuroleptic drugs, which really, for the first time in history, allowed patients with the most severe forms of psychotic disorder to be able to live in the community again. These drugs are not cures by any means. Some patients go on to do well with them, but they do tend to work at least to some degree, and many patients are helped by them. So it's an interesting shift, you know. So because the drugs seem to work, the drugs do work. A shift in the theory of schizophrenia ensued from a primarily psychological theory to a more biological theory. And we still have sort of a psychiatry that is dominated by biological theories of schizophrenia. I think the pendulum is swinging back toward a more biopsychosocial approach in the past decade or so. But much of the research and much of the funding on schizophrenia today is from a purely sort of biological perspective.
Now you mentioned that the drugs worked, and I know from having casual conversations about mental institutions in the 50s and how we used psychoactive medication. You know, the average person kind of goes, you know, oh, it was terrible back then. And I know there were at some point there were this idea of lobotomy was thrown around as a treatment. Um, uh, Are these criticisms fair in the sense of, you said that that Thorazine worked. Does work mean, making the hallucinations go away, but then there's no quality of life? Or did it work in a much better sense, and in terms of it allowed people to flourish?
Yeah, I think many of the criticisms are fair. I think psychiatry has a pretty dark history. When you think about lobotomy, you think about some of the other types of treatments that were sometimes done not to treat disease, but to punish unruly patients. I mean, I think that psychiatry sort of has to own up to some of this in the early 20th century to the mid 20th century. What does it mean when we say an antipsychotic drug works? That's a great question, right? I mean, um, so the drugs seem to be quite effective for the positive symptoms of psychotic illness. What I mean by that are the hallucinations. So hallucinations involve sensory misperceptions, hearing something that's not there, seeing something that's not there, smelling something, tasting something, or feeling something on your body that's not real, that's not really there in reality. And they can also, the medications can also be quite effective at dealing with delusional ideations. A delusion is a fixed false belief that is held against all evidence to the contrary. The mafia is tapping my phone. The Mexican drug cartel is hiding drugs in the walls of my apartment. Aliens landed in my apartment building last night and replaced my heart with a Glad trash bag, right? So these are examples of delusions. And the medicines more or less tend to be effective for dealing with the positive symptoms, what are called the positive symptoms, those that are added on, quote unquote, to ordinary human experience, hallucinations and delusions. They don't always work for hallucinations and delusions, but they're most effective for those symptoms. When it comes to the negative symptoms, blunting of affect, this is a common symptom in psychotic illness where the patient really is unable to express much or demonstrate much emotion. There's a sense that part of the personality of the patient has been lost. They start to withdraw socially. They have difficulties in interpersonal relationships. The drugs, frankly, are not very effective for these types of symptoms. And this is, I think, where psychotherapy plays an important role. Psychoeducation, psychotherapy, cognitive remediation, like cognitive enhancement therapy, um, communities for patients with psychotic disorders to help build and establish social skills and social interactive abilities and that sort of thing.
Yeah,
So
I've
do the
I've heard
drugs
this
work?
I've heard this quote that in some cases the drugs can allow talk therapy to be more effective. Is that a fair assessment?
Yeah, there's opinions on both sides of this. I tend to agree with this idea, um, with a few exceptions. I mean, I think if the patient is on such high doses of neuroleptic medicine, it can really it really can lead them to not really be able to engage much at all in the therapy process. They are, in essence, sort of zoned out. And sometimes people colloquially term this as like zombification if the person's on such a heavy dose of an antipsychotic. But for the most part, if the patient is adequately treated, the dose is right, I think the patient becomes more able to work in a psychotherapy versus if they are not treated pharmacologically. But it brings me to another, I think, important point. A lot of people have this idea that the patient has to be on medicine before they enter therapy. And I don't think that that's necessarily true. I think it can be helpful, but a lot of patients are much more willing to come talk about their problems than they are to take a drug. And sometimes in time, if you build a trusting relationship with the patient, you develop a good rapport, the therapy can be an avenue toward effective biological treatment too. I hear all the time that therapists in my community and probably all over, they won't work with patients with schizophrenia either at all or unless they're on medicine. And I think maybe this is driven by some liability concerns and some other concerns, but I think that that we ought not have that as a firm firm rule that the patient has to be on medicine before they come into therapy.
And what are some of these? What are the individual goals that you're trying to achieve in a talk therapy setting when working with somebody who's experiencing psychotic breaks? It seems, I know my gut goes, wow, that's surprising, to me that you can use talk therapy to address something so dramatic. What is the process? What are these little steps that you're trying to achieve in this in talk therapy when dealing with psychotic disorders?
Yeah. Well, it really depends largely on the type of therapy that we're talking about. Cognitive therapy or cognitive behavioral therapy has different goals. Cognitive enhancement therapy, which is a cognitive remediation, trying to build skills, social skills, and the like, is a different type of therapy. But I'm going to talk mainly about psychodynamic therapy, which is what I do and how I'm trained and that sort of thing. So, the first goal of a psychodynamic treatment is to establish a relationship with the patient that is marked by warmth and basic trust. And in the words of Harry Stack Sullivan, the therapist must provide the patient with a relationship of security beyond which the patient has ever had before. The patient has to feel completely safe with the therapist, completely safe to reveal any thought, any fear, any anxiety, any symptom. And this sounds relatively easy, but when you're working with patients with these types of illnesses, it can be difficult. So beyond just the therapeutic environment, if you will, what are some of the goals of the treatment? Right? So for me, one of the major goals is to help the patient understand how anxiety serves as a trigger for the symptoms. And very often the patient is able to say this even off the bat, that when I get anxious, when things are happening in my environment that I can't control, my symptoms worsen. And this is something that the empirical research, has shown for many years. So helping the patient understand the link between anxiety and their symptoms. Targeting the symptoms with specific techniques. And one technique that I find to be helpful is helping the patient identify when they enter into what's called the listening attitude. So right before the onset of a hallucination, the patient enters into this very temporary, transient emotional state in which they anticipate hearing a voice, for instance. If you can help the patient catch themselves in this listening attitude, this is a term that I borrow from Silvano Arietti, who was probably one of the world leader on schizophrenia for many decades. This can help them with the symptoms themselves. Understanding how in psychosis, and this is done sort of in the later stages of the treatment. You certainly don't want to do this early on. The early stages are really based on developing a good working relationship with the patient. But later on in treatment, you might actually help the patient to understand what the symptoms may mean. And so in the psychodynamic theory, there's this idea that the patient is actually engaging in a process called concretization. And the term means what it sounds like it means. It means that the patient is taking something abstract and making it concrete and literalizing a metaphor, right? So if the patient has an olfactory hallucination of an odor emanating from his body, a foul odor, that this may indicate that the patient actually feels that they are a foul or a bad person. The patient has concretized this inner belief or this inner fear or anxiety. In paranoia, the patient is projecting onto the outside world the patient's own hostile or critical attitudes toward the self, right? Instead of believing that one is bad and that one should be punished, the patient actually projects onto the outside world this belief and thus feels that people are out to get them. And this is sort of interpreted psychodynamically as a defense mechanism, right? That the symptoms, a classic idea in psychoanalysis is that the symptoms are at once a problem and a solution to a different problem. The symptoms are a solution to the problem of overwhelming catastrophic inner anxiety. This is the theory, at least, right? And the symptoms develop as a means of mitigating or dealing with that anxiety. And and this is certainly not um, contradicting a biological theory. I think that the biological and the psychological can occur, are complementary theories or ways of looking at schizophrenia and psychosis, by the way. But the idea is that the symptoms are serving some purpose. There's some reason why the patient is believing what they're believing. And this is sometimes why I get a little frustrated with some of the more biologically minded people who essentially say, well, the patient's psychotic. There's no point in talking to them. There's no point in trying to make sense of why the patient feels that he doesn't have a left arm anymore, or that his heart has been replaced by a CD-ROM or something, right? But to me, nothing happens by chance. Nothing in the mental world happens by chance. There's always some meaning to be derived. Whether we can actually derive meaning from the symptoms is another question. Sometimes you try for years and you fail and you really can't make any sense of it. But I think the meaning is there. So over time, and this is sort of in the later stages of psychotherapy, the patient might actually be able to say, well, when I feel paranoid, I know that that's just a projection of how I feel about myself. That's actually
Wow.
my own inner thoughts and my beliefs about myself. So we talk about self-esteem. We talk about how self-esteem was impacted often by early experiences and sometimes trauma, and the like. So that's sort of psychotherapy from a psychodynamic perspective in a nutshell.
Yeah, and it just listening to you say that, it almost makes me feel, it makes me feel a lot more empathetic towards people with these conditions, because I mean, in a much less intense way, that's how most people have a couple coping mechanisms that aren't ideal. You're you're mad at your spouse, and that causes you to maybe perceive some things they do in a more negative light. It adds a negative lens. And it sounds to me almost like what you're saying is these beliefs, delusional beliefs about the government, are I mean, are they just a slightly more intense version, or is it silly for me to compare those two?
Yeah, I mean, you're really getting at the question of, well, are we dealing with a categorical problem or a dimensional problem? And this is a question that has plagued psychiatry and clinical psychology for decades, right?
Hmm.
Is schizophrenia just on the extreme end of a spectrum? Do all of us sort of have some proclivities towards psychosis, but we don't reach the threshold, right? This is an interesting question. I wrote a piece last year titled Schizophrenia, a Difference of Kind. And I argue that we're actually dealing with a categorical difference, right? So my argument in the paper, without getting too theoretical, is that all differences in nature are essentially quantitative ones, right? But it's the
Hmm.
difference in the quantity that produces the qualitative or the categorical difference, right? So a normal person may experience mild psychotic symptoms either upon falling asleep or waking up in the morning. These are called hypnopompic or hypnagogic hallucinations. This has happened to me once or twice before. I wake up in the morning and for a split second, I hear my voice being called. And then I come fully awake and I realize that there's nobody calling my voice. This is a normal experience. I think it occurs roughly in 40 to 50% of the population. But an anxious person might believe that their boss is talking behind their back, or a
Right.
jealous spouse may have a fit of paranoid rage, right? My
Hmm.
spouse is cheating on me, or my spouse is doing X, Y, and Z. But as long as these experiences are quantitatively so minimal that the individual can keep them in check, that is, that they don't produce any impairment, then we don't consider these people to have schizophrenia, right? It's only when the quantity of the symptoms reaches a certain level, when the symptoms gain the upper hand, creating dysfunction and impairment in the individual's life, as when as the psychiatrist Arietti put it, the way of living of the patient expresses itself not in contrast to, but in accordance with the symptoms that the person has schizophrenia. So I think at different quantitative levels, we have such dramatic changes in the experience of the symptoms and their persistence and the degree of impairment that I think it acquires a qualitatively or a categorically different nature and is ruled by different
Hmm.
mechanisms. So I tend to argue that schizophrenia is a disease, a categorical disease that differs from normality for that
Hmm.
reason.
Yeah, I tend to agree. I've heard a similar debate when when you start getting into addiction. It's uh, everyone it's pretty normal to have a few beers every now and then, have a glass of wine. That's fundamentally different from being an alcoholic or needing intervention, right? I've heard lots of different
Yes.
versions of how you differentiate between needing intervention versus not. Does it affect your relationships? Does it reflect your health, or does it impact your relationships, your health, or your job? And you pursue it in spite of different consequences. But I totally agree. There seems to be some sort of categorical difference, even though, like you said, the average people might have delusional beliefs that sort of creep into their everyday life.
Yeah, 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 exactly. So yeah, it raises interesting questions about conspiracy theories, and I saw that you might have wanted to touch on that. That's not an area of expertise for me, but those who are interested should look up Joseph Pierre. He's a psychiatrist at UCLA. He does a lot of writing on conspiracy theories,
Yeah, he's
and
actually the next interview I have scheduled is with Joe Pierre. So I was
that's great.
hoping that we didn't get too far into talking about conspiracy theories, but it's so funny that you brought that up. Um, so yeah, so we won't touch on conspiracy theories, as interesting as that topic is. But in closing, I do want to talk about homelessness and people experiencing homelessness. Um, Personally, I don't feel like calling these populations homeless does them any good. I feel like that's a misnomer. I try to push the term that they're publicly mentally ill. I know that that's a percentage. It's not all of them. I know that it's sort of a combination of illness and drug use that is going on in these populations. Um, it's probably the easiest way for an average person to see psychosis with their own two eyes. If you've ever seen somebody walking up and down the sidewalk, sort of talking to themselves, that's sort of that type of thing. Um, could you? I know it's not your, you're not a public policy maker, but could you talk a little bit about what things public policymakers get right and wrong about addressing homelessness and their symptoms?
Yeah, it's such an important question. Um, well, I mean, I think that one of the major problems is that we don't really have a mental health system in this country. We really have a non-system. We have revolving door hospitals where if the patient is hospitalized, they're there for 3 or 4 or 5 days. They might get started on a neuroleptic medicine, their symptoms might improve, but they have no place to live. They have no money. They probably don't go to the pharmacy to fill their prescription. They live on the streets, and thus, addressing this sort of solely as a problem of beds, of needing more beds, while I think is well intentioned, psychiatric beds, that is, I think it misses a large part of the problem. I think the entire philosophy of treatment has to change. Um, as bad as the state hospitals were, and believe me, from what I know about history, and I teach the history of psychiatry, some of them were absolutely horrid places to live. The idea, though, of having a place for the severely mentally ill to live, in many of these hospitals, from years ago, they had patients work the grounds and garden, and there were activities that they could engage in. I don't know if that's the solution. Some people have proposed, sort of maybe reopening in some very progressive and different type of way institutions like that for folks, because we've gone from 600,000 people in state hospitals now with severe mental illness to 350,000 in prison, and another 250,000 homeless on the streets. So, I'm not a public policy guy. It's not really my area, but I think it has to be a multi-pronged approach for sure.
Yeah, I know Michael Schellenberger, who was running for office in California, I think he was a big part of his platform was having to sort of bringing back these state facilities. Um, yeah, it is a tough question to answer. I don't know if you would agree that there's this sort of the voluntary versus involuntary piece is where I see a sort of disconnect. I because I live in a downtown area, I frequently interact with the homeless populations, and I mean, I wouldn't say that I'm interacting with the ones that are experiencing psychosis. Although what I have learned is that even for some of them that are sort of talking to themselves, they can very easily sort of snap into a conversation. Uh, some of them, right? Maybe not all of them, but some of them can go from sort of loudly yelling about the government to, you know, buying an apple at the grocery store, something like that.
Yeah, yeah,
Um,
yeah.
in terms of that voluntary piece, or do we need to sort of have the expand conservatorship, which is this idea that we need to take the most mentally ill homeless people and sort of bring them in and force them into treatment, or do you think that there's a way to persuade them?
Mm. It's a great question. I think it's a nuanced topic. I am, I believe chiefly in voluntary treatment. With that being said, I do think that there is a role, and I think there's a role for the state in enforcing treatment on patients who are so ill that they are unable to function and they're unable to recognize their own illness. I think a good having worked inpatient and in the emergency room, that the rules or the laws are so stringent nowadays. The person has to be imminently dangerous in order to be admitted to the hospital under an involuntary commitment. That's actually is actually a high bar. In California, there is a not a requirement. I suppose we can say requirement for grave disability.
Mhm.
The person doesn't have to be suicidal or homicidal. All they need to be is gravely disabled by their mental illness to be admitted to the hospital involuntarily to get restarted with treatment. And I think that using that model perhaps might be more helpful. The suicidal homicidal bar, which really is a byproduct of a lot of litigation and sort of civil libertarian thinking when it comes to the mentally ill. Tom Saz was an anti-psychiatrist who had a lot to do with this. People should have the right to be as crazy as, excuse me for using the language, but he would argue people have the right to be as crazy as they want to be, as long as they're not harming anybody else, right? And there's a part of that argument that I'm sensitive to. I do believe in freedom. I believe in
Right.
personal freedom. But when the organ that is diseased is the very organ that is the organ that we use to make decisions in our own best interest, I think we're dealing with something very different from, say, a patient who's declining treatment for their cancer or for their cataract. When the very organ, the brain, that is diseased, that is used to make decisions, I think we have to take that into consideration. I don't think we do a very good job of doing that societally.
Yeah, and the lack of Dr. Drupinski, he always, when he's talking about this topic, he'll say that lacking insight into what they need is a symptom,
Mm-hmm.
right? And
Yeah,
that's sort of what twisted my that's what sort of got me thinking a lot about this topic.
yeah, 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 exactly. And I think Dr. Drew has done a lot of good, advocacy work for improving the condition of really some of the most vulnerable people in our society.
Well, thank you so much for being on. We've run out of time. I appreciate you coming on. I know that you're very passionate about psychiatry, especially the history. I wish we could have gotten a little bit more into this deinstitutionalization, but perhaps another day. Thank you so
Absolutely.
much. Thank you so much for being on, Dr. Mark Ruffalo.
Thank you so much for having me. It's been a real pleasure. Thanks so much.
For more on Mark, visit drruffalo.com. That's drruffalo.com. Or follow him on Twitter at Mark L. Ruffalo. Be sure to follow the Why Do We Do That Facebook page for updates and additional content. Don't forget to rate and write a review on Apple Podcasts. Follow on Instagram at Why Do We Do That Podcast or Twitter at WDWDTpod. As always, feel free to email me at whydowedothatpodcast@gmail.com. Until next time, this is Dr. Ryan Moyer, hoping you found some answers to the question, why do we do that?